Thank you. I'd like to acknowledge my collaborators, Dr. Chernos, Dr. Park, Dr. Hardy, and Dr. Vergas. So gastrointestinal endoscopy training and certification is standardized in the US and the UK through programs such as Fundamentals of Endoscopic Surgery and the JAG endoscopy training system. In Canada, it is not currently standardized. This is important for public safety and trust because general surgeons currently perform over 50% of endoscopy in Canada. Thus, the objectives of our study were first to assess the current status of flexible gastrointestinal endoscopy curricula and performance assessments in Canada. And our secondary assessment was to assess procedure numbers, perceived competency, and perceived preparedness for independent practice. We performed a descriptive cross-sectional study using an online anonymous survey of general surgery program directors that was conducted from July to September 2017. We used best education practices and evidence-based endoscopy curriculum guidelines to develop a 35-question survey that included information on program demographics, endoscopy curricula, performance assessments, and outcomes. We did bivariate descriptive analyses. For predictors of program outcomes, we did Pearson's correlation coefficient and student t-test, and we did a narrative description of open-ended questions. We had an 100% response rate after multiple reminders. There was an average of 38 residents per program, and an average of 2.8 months of dedicated endoscopy training per program. One offered a longitudinal experience and one offered no dedicated endoscopy rotations. In terms of endoscopy curricula, for pre-rotation cognitive skills training, approximately 50% had training in conscious sedation and approximately 40% had any type of cognitive skills curriculum prior to starting the rotation. In terms of technical skills training prior to the rotation, approximately 80% had access to an endoscopy simulator and only 50% had any sort of technical skills training. During the endoscopy rotation, cognitive skills training included 40% had a cognitive skills curriculum. The most common one was the Surgical Council on Residency Education curriculum. In terms of technical skills curriculum, 75% had access to a clinical acute GI bleed exposure. In terms of the endoscopy trainers, the most common was academic surgeons at 48%, and tied for second was community surgeons and academic GI at 22%, and community gastroenterologists were 8% of trainers. No trainers were required to take pedagogic endoscopy training programs. In terms of performance assessments, pre-rotation skills were examined with a cognitive exam in 2 programs and a technical exam in 3 programs. In terms of post-rotation and cognitive skills, 2 programs had a written exam, 1 had an oral exam, and 14 relied on feedback. And on post-rotation technical skills assessments, 4 had an objective exam, 5 reviewed the resident's endoscopy logs, and 13 had relied on feedback. In terms of the number of assessments, the highest was 5 per program, the lowest was none, and the average was 2. Only 1 program required residents to obtain FES certification. 73% of program directors agreed that residents were prepared for independent endoscopy practice, and 4 disagreed that residents were prepared. In terms of numbers of procedures, endoscopy, there was approximately 82 gastroscopies performed during endoscopy rotations compared to 156 colonoscopies, and there was 150 gastroscopies performed over a resident's entire residency, and 241 colonoscopies on average. This graph, we assessed programs directors' perception of resident competency on several different skills, including snare polypectomy, hemorrhoid banding, PEG, argon plasma, coagulation dilation, push enteroscopy, EMR, variceal banding, stents, ERCP, and endoscopic ultrasound as per evidence-based curriculum guidelines. 4 indicated competent, and we found that the only skill that program directors felt residents were competent in were snare polypectomies, and the remaining did not reach the level of competency. In terms of procedure numbers, we found that it was not associated with the robustness of an endoscopy curriculum, and it was correlated with the months of dedicated endoscopy training. When we looked at competency, endoscopy curriculum was not associated with competency or procedure numbers. Endoscopy curriculum was not associated with preparedness for endoscopic practice, although procedure numbers was associated with the perceived preparedness for independent practice. Moving to the open-ended questions, we had approximately 60% response rate. And this is a word cloud demonstrating the 20 most common words in the open-ended questions. Themes that emerged were program directors acknowledged that formal endoscopy curriculums were needed, that there was a lack of acute GI bleed exposure, that there was limited volume of surgeon endoscopy, and there was competing interest with gastroenterology. And this quote was really representative. If endoscopy training were a joint effort between GI and surgery, overall training would be significantly better. In conclusion, there's high variability in Canada in terms of training, performance assessments, and program outcomes. There's an awareness of the limitations of the current system, and this is particularly important in the era of competency-based medical education. I think this is a good opportunity to establish standardized practice. Limitations of our study included this is self-reported measures, this is a survey and the survey and the metrics are not validated, and it is a small sample size, so a lot of the correlations that we were looking for that weren't significant, I don't think you can really conclude much. Yeah, thanks.